Hi, this is Dr. Agostino Cervone. I'm here to talk to you about ventral hernias. As you can see, this patient has a ventral hernia. Just underneath his belly button, there is a thinness of the wall of the abdomen that allows protrusion at that area. Along with trocars that go in the lateral abdomen that I've placed here, I'm able to pass instruments that allow me to grasp what's going into the hernia as well as dissect the hernia sac. Here I'm taking down the inner lining of the abdomen with the use of endoshears, or these fine laparoscopic scissors. Using the endoshears as well as electrocautery, I can take down the fatty tissue to ensure that when I place a mesh that is typically placed laparoscopically when fixing hernias, this mesh lies flat up against the underside of the muscle or the abdominal fascia. As you will see, the mesh will lie flat against this surface, enabling the mesh to incorporate into the patient's fascia. We do want incorporation, or can be in layman's terms scarring of the mesh within the abdominal wall so that it stays put and creates a repair of the ventral hernia. Occasionally, ventral hernias will contain incarcerated tissue, in particular fatty tissue as well as the intestines. When this happens, general retraction and lysing the adhesions, similar to what's being done here, helps remove the incarcerated tissue in order to accommodate visualization of the abdominal fascia. Once the dissection is performed, a mesh is placed in the abdomen. These meshes that we particularly use for laparoscopic hernia repair have various coatings that dissolve in a matter of days in order to prevent too many adhesions to the underside of the mesh. Here I'm using a light mesh with a coating that will dissolve in a matter of a week to 2 weeks. Sutures are placed at the middle of the hernia in order to help orient the mesh to the anterior abdominal wall. Using this suture grabber, I'm able to elevate the mesh anteriorly, as you can see here, or laying it up against the ceiling of the abdomen. Once this happens, then I can use a series of tacks in order to fasten the mesh to the anterior abdominal wall. Here I am using an absorbable tacker, and I would say most surgeons tend to use an absorbable tacker to help fasten the mesh. The goal in doing so is to allow the mesh to lie and become scarred in or incorporate into the abdominal fascia. These tacks in particular will last approximately 9 months according to the manufacturer. But I can tell you from experience that within a few months these tacks are starting to dissolve. Not only have I tacked circumferentially around the mesh on the outside, but I'm also going to place tacks around the primary hernia defect. This helps keep the mesh in place for the healing process. I will say that applying a mesh laparoscopically in this fashion causes a little more postoperative pain than as if this hernia was done through an open incision. But the advantage of doing it this way is faster recovery, less chance of infection, and it allows the patient to be done as an outpatient, meaning that he can go home the same day. And at the completion of the mesh placement, the carbon dioxide that's used for creating a pneumoperitoneum is allowed to escape and deflate. Thank you.